in the last few days, and the PTK is to set priorities and first of all to correct the high order aberrations and therefore to take care of clarity and the fear. We have a number of principles. Number one, it is quality that matters more than quantity. Second principle, it isn't cosmetic surgery, it's therapeutic surgery. So the third principle is that opacity isn't important, but the surface irregularities are much more important because these are the ones that cause the high order aberrations. So for instance, with this glass you can't see anything, whereas through sunglasses, which are far from being clear, after PTK you may see despite the opacities. And this is the typical case. This is keratoscopy before and after. There are still opacities after 3 years, but the patient has a good visual acuity. So here as well. So if it is regular, if the surface is regular, the visual acuity comes back. And at a Scheinflug, we may see also that the opacities are still there, but if we corrected the opacities, this is a comma, we have 8/10. There is another principle. You shouldn't be in a hurry. You shouldn't rush doing things. So we perform these, we subdivide these treatments in a number of steps on the same day or in the same surgical session, and there is a fifth principle, that is to say, there isn't a fit-for-all size. The treatments must be customized. So here we may see that the patient is laid down on the bed, and then laser has to be performed. So we then ask the patient to stand up, and the patient goes into an adjacent room where we perform all tests and exams. So this is still a bit neglected. Topography can be performed even without the epithelium in place. So this is a patient who's just got out of the laser room. So we keep his eye open for him, and let's have a look at the keratoscopy. It's very high quality, so we can remeasure everything right away, and we decide another ablation session is necessary on the same day, immediately after. So this is the system: topography, tomography, high order aberrations, everything in one shot. So on the basis of this, we may differentiate between the situation as it was just a few seconds earlier and decide what to do. So it's a sequence. Let me show you. This is a corneal ulcer. This is the visual acuity +7. And this is the topography. This is the tomography. This is the epithelial map. And this is the pachymetry. So we have planned an ablation. The ablation aims at removing a lot of tissue where the tissue is abundant in order to reduce the coma. But at the periphery, of course, at the extreme periphery, this will be flattened down and this will get more curved. This is the first step. I'm not happy yet, so I bring back the patient into the room for the second step. This is the map and this is the ablation. So there will be an ablation here in order to enhance the curvature, nothing where there is a flattening. And so as a whole, it's 10 microns. But look, how important 10 microns are, but I'm still not happy. So a third step to ablation, two ablations, 38 microns more at the periphery where there is a lot of tissue. Okay, it's even better. It's a bit better, but not enough yet. So a further step to correct the residual central astigmatism. There is a lot of tissue, so this is 21 microns ablation, and this is the final result. This is a tangential map. So prolate cornea has been reconstructed without a coma, without nothing. So if you consider the evolution of the cornea in time, here there is no coma and the patient has recovered 10 over 10. So this is great. And as in an iceberg, we've got to look below the sea surface and therefore the epithelium, because the epithelium might have peaks where there is 180 microns thickness. Unless you have ablated everything what the epithelium tries to mask and hide, you won't get anywhere. So it isn't enough to say this cornea is 500 microns, but what is the stroma? So, because that's where you should measure it, not here, because the epithelium doesn't matter. And the third principle is that thickness is not the limitation or limitation. In 2005, we published a follow-up, 9-year follow-up for patients having residual stroma, 250 microns. We followed them up. This is one patient whose coma had been corrected with intense ablation. But if you look at the follow-up after 4 years, it actually increased by nearly 90 microns. It isn't epithelium alone, also stroma actually grew. So this is the approach, so sequential, customized, and transepithelial. Okay, top priorities. Where is tissue available? Can we perform ablation? And to shift the ablation where there is tissue available, because this is the approach. And yet another example, we have a clover leaf and we have an acanthamoeba ulcer, and we see the total thickness, the opacity, and the localization of it. And then the the visual acuity is quite low. And we have an option here. We may ask the tool to perform an ablation aiming at a high order without being worried about possible refractive errors. This is the ablation. Then we may also decide that we don't want to correct the high order aberrations, which weigh less than 50 microns. And then we have here subtracted the tissue around the thinnest tissue, and this is the final outcome. 9 over 10 and a residual cylinder that we didn't aim for actually, but the cornea is okay and there is no opacity left. And it isn't true that with a deep ablation the opacities are resolved. This is the situation, or not resolved. This is the situation after 1 year. Let me also show you on blood vessels. Blood vessels invading the cornea, as here. If you regularize it, this is OCT. So if you regularize the epithelial thickness, and this is the evolution step after step, and you improve this evolution over time, the vascularization disappears in about 1 year. And this is yet another example. So even though the PTK may fail, however, you can adopt this or take this approach. This is herpes. So these cases cannot be measured in advance because keratoscopy at the Scheiflung is not processed. So first of all, raw data, and then measuring allows us to shift from here to here and to regularize. And this is the final outcome we have achieved on a cornea that might look at as absolutely impossible to treat. You might wonder, how can we rely on and trust your pre-op measurements? Okay, let me show you this case. This is the situation, all the pre-op measurements, and then let's measure after 1 week from the last treatment. It's reliable. Look at the difference in terms of OCT and epithelium. So we can certainly trust this and rely on it. And this is similar to the initial case, 3 treatments for surface keratectomy. you may regularize a patient who otherwise should be transplanted. So mind you, the opportunities and the possibilities to treat extreme cases by means of a PTK are much more numerous and broader than expected.